Intraocular lenses. Placement of an intraocular lens following removal of a cataractus lens is the gold standard in modern cataract surgery. Selection of the type of IOL will depend on the following factors: type of cataract procedure used, anatomy of the anterior chamber, presence of underlying ocular disease, and the surgeon's preferences. Placement of IOLs depends on the capsular bag support. An intact capsular bag would allow placement of IOL within the capsular bag. Capsular bag IOL implantation has the following advantages. IOL is positioned in the proper anatomic side. Both loops are placed symmetrically in capsular bag with less incidence of tearing of zonules by IOL loops. Lower rate of dislocation or decentration. IOL is positioned away from corneal endothelium, iris pigment epithelium, iris root, and ciliary processes. In the bag, IOL implantation is safer in children. Posterior capsular opacification may be reduced. IOL may be easier to explain if necessary. Absent adequate capsular support would prompt placement of an anterior chamber IOL, where the lens is totally supported on the iris, or a sulcus fixated posterior chamber IOL. Pathology of intraocular lenses. Decentration. Ideal IOL fixation would be in the bag, following continuous curvilinear capsular axis. Anatomic considerations. An empty capsular bag diameter is 10.5 mm. Most IOLs for in-the-bag fixation are one piece, with diameter 12 to 12.5 mm. Ciliary sulcus diameter is 11 mm. Total lens diameter of 3-piece flexible loop IOLs for sulcus fixation varies from 13.5 to 14.5 mm, allowing a snug fit in the ciliary region. Causes of decentration. Asymmetric implantation of posterior chamber IOL loops results in sunrise or east-west syndromes. Escape of a loop may occur intraoperatively after dialing of the IOL or post-operatively because of gapping anterior capsular tear or a large capsulotomy with minimal residual anterior capsular support, P-pod effect. Sliding of a loop between the iris and anterior capsular bag, too short total lens diameter. Perforation of a loop through the iris or an iridectomy. Optic migration during pupillary capture. Loop bending or fracture with resultant shortening during manipulations. Capsular rhexis contraction syndrome with plate-style IOLs. Decentration results in significant visual symptoms as glare, halo, monocular diplopia, or visual aberrations. Inflammation. Non-infectious causes. Toxic lens syndrome, inducing sterile endophthalmitis due to poor quality design IOLs, anterior chamber, iris supported or poorly polished. Breakdown of blood aqueous barrier due to excessive manipulations inducing anterior segment inflammation, flare, cells, and sterile hypopion, UGH syndrome, uveitis, glaucoma, hyphema syndrome. Infectious causes. Endophthalmitis. Infectious endophthalmitis is a possible complication of any intraocular procedure, including IOL implantation. An intact posterior capsule creates a barrier effect that may prevent posterior extension of bacteria. Endophthalmitis can follow NDAG posterior capsulotomy for posterior capsular opacification. Chronic endophthalmitis. It is a localized smoldering infection within capsular bag due to sequestration of low virulence organisms within the lens capsule, including Propionibacterium acne and Staphylococcus epidermidis. Chronic endophthalmitis is frequently seen with polypropylene IOL haptics due to bacterial adherence. In chronic endophthalmitis, there is delayed persistent postoperative panuveitis. Organisms hide within lens equator and capsule. Localized endophthalmitis necessitates removal of IOL and capsular bag remnants for successful treatment. Crystalline lens-induced granulomatous inflammation, phacoanaphylactic, phacoantigenic endophthalmitis. This is an inflammatory response to exposed lens protein, inducing a cell-mediated autosensitization to the patient's own protein. The onset is between 1 to 14 days after lens protein exposure, extracapsular cataract extraction, or penetrating trauma. There is zonal granulomatous inflammatory reaction to lens capsular remnant, with central polymorph nuclear leukocytes reaction surrounded by concentric layers of inflammatory cells, including epithelioid and giant cells, also foamy macrophages. Iris and ciliary body show plasma cells and lymphocytic infiltrate. Chronic uveitis may end in phthisis bulbi. Conditions of intraocular lenses: corneal endothelial damage and decompensation, pseudophakic corneal edema and bullous keratopathy, due to mechanical endothelial chafing by anterior chamber IOL, anterior lens dislocation, post-operative chronic subclinical inflammation at the loop fixation site with release of inflammatory mediators inducing endothelial cell damage and cystoid macular edema. Retrocorneal fibrous membrane proliferation. There is fibrous metaplasia of corneal endothelium, stromal ingrowth through breaks in Descemet's membrane, conjunctival connective tissue invasion, and fibrous metaplasia and proliferation of iris stromal cells and pigment endothelium. Complications of intraocular lenses: pseudophakic cystoid macular edema due to increased permeability of perifoveal capillaries, ischemic tissue injury, secondary to intraocular inflammation with prostaglandin release, or due to direct traction on the macula following vitreous shift. Cystoid macular edema occurs 4 to 12 weeks post-operatively. In cystoid macular edema, there is small cyst formation around the fovea in a flower petal pattern. Fluid accumulates within the outer plexiform layer around the fovea, Hans fiber layer, where the photoreceptors processes radiate away from foveal pit to synapse with bipolar cells. Spaces appear empty on fixation. Retinal detachment. Incidence of retinal detachment following cataract extraction. The incidence of retinal detachment in aphakic eyes or following intracapsular cataract extraction is 1.5%. Incidence with extracapsular cataract extraction with or without IOL is 0.55% to 1.65%. Incidence of aphakia in patients with retinal detachment 7 to 43%. Type of IOLs may render visualization of periphery more difficult in patients with retinal detachment. Posterior capsular opacification or PCO. Rate of PCO after extracapsular cataract extraction and IOL implantation at 26 months is 18.4 to 50%. PCO is age-related as it occurs in 100% of pediatric extracapsular cataract extraction within 2 years of surgery and drops below 10% in patients over age of 70. In PCO, there is epithelial migration from equator and anterior capsule posteriorly, residual cortex, bladder cells originating from migrating anterior capsular epithelium, forming Elching pearls, fibrocyte-like cells derived from pseudofibrous metaplasia of lens epithelium. Myoepithelial cells are contractile smooth muscle containing metaplastic lens epithelial cells. Complications of residual lens epithelial cells include posterior capsular opacification with visual impairment, especially in pediatric age, IOL optic decentration or loop distortion, phacotoxic or phacoanaphylactic inflammatory reaction to retained lens fragments, localized endophthalmitis, summer ring formation with poor visualization of retinal periphery. Methods reducing posterior capsular opacification: atraumatic surgery, minimizing intraoperative and postoperative inflammation, thorough removal of all cortical remnants in equatorial region during extracapsular cataract extraction. In the back fixation of IOL, this results in posterior capsule stretch with apposition of IOL optic against the back, creating a barrier effect against epithelial migration. IOL design: biconvex IOL design or posterior convex optic with sharp optic edges. Bioadhesion bonds between optic material and posterior capsule due to soluble fibronectin, vitronectin, and collagen type 4. One-piece all. Polymethyl methacrylate C-loop design
hydrophobic acrylic and silicone IOLs.